Welcome everyone to today's webinar. I'm Anuja Vaidya, Assistant Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a question for staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to introduce today's presenter. Richa Singh has served in senior sales management positions for 10+ years. She was employed in the information technology field, first with Cisco Systems and then with Vocus, one of the nation's leading companies in public relations software. Her IT experience has provided her with key skills applicable to her current role at CollectRx. Ms. Singh also served as account executive for Merrill Lynch. Having joined CollectRx in 2010, Ms. Singh now serves as CollectRx's Executive Vice President of Sales. Her responsibilities include developing and implementing corporate-wide sales and marketing strategies, sales management reporting and systems, overseeing the sales, marketing, account management staff and functions, and serving as lead relationship manager with several of the firm's largest clients. During her tenure at CollectRx, she has been instrumental in the firm growing its client base to more than 1,300 healthcare provider organizations located throughout the country. Ms. Singh holds a bachelor's degree in computer science from the University of Maryland, supplemented by certification programs and advanced training in sales management information systems. At this time, I will hand the floor off to Ms. Singh to begin the presentation.
All right, thank you, Anuja, and hello everyone. My name is Richa Singh, Executive Vice President of CollectRx, and I'm happy to be here today to present to you all frequently asked questions in out-of-network. And many of these questions, they come from audience members from the numerous webinars and talks that we've presented over the years. So some of these questions, they might seem basic, but some do get pretty intricate as well. And we've organized sections for the different topics that people have asked us questions about. So first, what I'll do is start with a background on CollectRx and our out-of-network expertise, so you understand why we're in a position to discuss this. Then we will ask and answer frequently asked questions regarding the following topics. So general out-of-network issues, payment processing, policies, negotiating settlement offers, appealing underpayments, and finally, third-party rental network agreements. And our goal today, when we're done, is to answer the most commonly asked questions and familiarize you with some of the intricacies required to successfully run an out-of-network operation. So before diving into these topics, let me first provide a quick summary of our experience in out-of-network reimbursement. That way, again, you'll understand why we're in a position to address these issues. So despite our name, CollectRx is not a collections agency, and we have nothing to do with the pharmaceutical industry. But simply put, what we do here at CollectRx is we help providers get higher reimbursements on out-of-network bills. And we don't do this as consultants, but we do it more as experts in negotiating higher reimbursements on out-of-network bills. CollectRx, we are the only company in the country that's focused on helping providers get higher reimbursements on out-of-network bills, and we've been doing this since 2006. We work with more than 1,300 customers nationwide and process over $1 billion in out-of-network claims each year. Now, we work with all sorts of provider types, so obviously surgery centers, physician practices, hospitals, behavioral health centers, labs, basically anybody that's seeing out-of-network, we're working with. Now, to get the results that we get, we rely on two main sources. So the first is CRIXIS, which stands for the CollectRx Information System. And this is the proprietary data and analytics tool that we've developed to support us as we go toe-to-toe with payers. Now, CRIXIS, the database, it actually analyzes insurance policies, it provides comparable data, And it also allows us to track the tendencies and trends of the people on the insurance side. Now, the second component to our success is that we rely on our expertise, and we've built a great, unique team of out-of-network experts who used to work for the insurance companies and their vendors. So this puts us in a unique position to understand the soft spots in the payer's position and get higher payments on out-of-network bills for our customers. So first, let's start the FAQs with general out-of-network questions. And some of the questions that are asked today may have words that are unfamiliar to some, or you might use a different terminology for the same idea. So before we dive into the questions, I'd like to provide a couple definitions of some of the concepts that are used in these questions today. So the first one on this slide is out-of-network, and this might sound like a basic term, but providers that take a mostly in-network position might not be completely aware of exactly what it encompasses. So a provider that is out-of-network with an insurance company, they have not negotiated a contracted rate for reimbursements with them. So when a patient with that insurance is treated by the facility, the bill that the facility sends to the payer, well, that's an out-of-network bill. All right, the next term is repricing. And this is when an insurance company reimburses a provider at an amount that is different than the provider's full bill charges. And with out-of-network, this is usually at a much lower amount. Vendors. These are third-party companies that insurance companies use to reduce payments to providers. And payers, they outsource their bill minimization tactics to these vendors, either through negotiating high discounts from providers or repricing their claims to very low amounts. And then the last term here is that single case agreements. These are also referred to as settlement offers, proposals, or LOAs, or letters of agreement. So a payer, they send an offer after services are provided and after the patient leaves the facility, but before the insurance company actually makes the payment to you. So this is all in return that the provider may not bill the patient for that discounted amount that they agreed upon with the vendor. Okay, let's go into the first FAQ, and that is, what is the #1 key to successful out-of-network negotiations? So this is what we like to call the persistence game, and it's who's gonna win the battle of the wills, basically. The payers and the vendors, they put up obstacles to success, and they're banking that you will get up and walk away. And their goal, their sole aim, is to get you to throw in the towel. They know that you're busy, you don't have the time to continue the fight. And just so you know, the vendors, they're paid on a commission basis. So the higher the discount they negotiate, the more commission they make. So when you give up, they win. And ultimately, to succeed, you must have the persistence to continue fighting for the reimbursements that you deserve. So for example, persistence can come in a couple ways. When you're negotiating settlement offers, respond to every single counter offer, because they are hoping to wear you out by consistently going back and forth multiple times in a very short time frame. Whenever you're appealing underpayments, a common delay tactic used by insurance companies is to tell you the claim is still processing and to check back in 10, 15, 30 days. A lot of providers will see they'll drop the ball after the second or third time they're told this, but again, if you stay with it, you will see results. Okay, if I am currently out of network and there is no third-party rental agreement, is there still a strategy to negotiate? Yes, of course. On a bill-by-bill basis, vendors will attempt to minimize reimbursements through either the following means. First, they might negotiate a single case agreement, which I just defined earlier. And in these cases, again, you may engage in negotiations with the vendors to maximize your reimbursement. And again, you agree not to bill the patient for that reduced amount. And the other way that you can negotiate is when the insurance company just simply underpays you instead of first attempting to negotiate your payment. So they send you a check for a low payment along with the explanation of benefits. And from their perspective, the insurance company takes the position that they've already met their obligation in paying the bill in full to you. So in these instances, you need to engage in a full-on appeal process. Okay, what's the best way to negotiate with payers? Is it phone, email, or fax? Definitely start with the phone. I know it's the most time-consuming, but it is the best way to optimize your results. Is it worth the trouble negotiating if we don't see a lot of out-of-network? Yes, you should always negotiate out-of-network bills because the margin to increase these reimbursements is so wide since you're usually only allowed a fraction of your full bill charges. Even providers with low volume but that employ a strong negotiation process, they're able to generate significant additional dollars that would cover the cost of even 1 to 2 FTEs. So think of it this way, even if your lowest volume in-network payer told you that you're going to increase your reimbursements by 33%, and that's about the average that we do for our providers, you take it, right? We're trying to say that any additional money is worth the negotiation. Can I do anything if the bill was denied for no authorization? So sometimes, not all the time, but sometimes you can get authorization after the fact. So don't just give up on your claim if your claim's denied for that reason. Try to go back and get authorization. Okay, why would I want to be out of network? Well, it's more money. So out-of-network reimbursements are higher and sometimes much higher than in-network reimbursements when done right. And as providers survey the landscape today, there just aren't a lot of opportunities to improve reimbursements. Because if you think about it, your in-network contracts, they are what they are. I mean, it's hard to change what you've negotiated. With respect to Medicare and Medicaid reimbursement rates, there really is no opportunity to change those rates, but you can definitely leverage higher out-of-network reimbursements. It represents the last great way for a lot of providers to bring more dollars in the door and improve the bottom line. Okay, now let's turn to questions on payment processing. And the first question in this section is, how do payers determine what to pay? So this is something we're asked a lot of providers are unaware of this. And when an insurance company sells to an employer group, the employer group has the ability to dial up or down the out-of-network benefits. So this means that the more that they pay for health insurance premiums, that's the more that can be reimbursed. And vice versa, the lower they pay for premiums, the less that's reimbursed. And these dials, they come in at all sorts of different levels. So first off, does the payer negotiate settlements with the provider? And if so, at what rates will they do it? Second, when a bill is repriced, what is the maximum amount that will be paid? Third, if a provider or patient pushes back on the low payment, what should the payer do? So it can range between what the payers call stand-on data, meaning that it doesn't move at all to increase payments on one end, to making fairly drastic concessions to eliminate patient noise on the other end. Now, this is a spectrum, and employers, they can choose to be anywhere along this range. But just so you know, whatever the employer chooses, the payer is always going to have data to support their position. Okay, how can I have two patients with the same treatment and the same insurance company, but two different reimbursements? So this is very similar to the last question. Ultimately, again, it's not the insurance company that defines the reimbursement level. That decision, again, is controlled by the employer group. So not only do the employers determine the out-of-network benefits, but they control the methodology being used to determine the allowed amount. So on occasion, however, there may be a difference even within the same group. So you do need to make sure you're vigilant in reviewing your EOBs to catch if this happens. My revenue cycle team insists that usual and customary is limited to 150% of Medicare for out-of-network. What are your thoughts? So there is no way that all payers in an area are limiting all out-of-network reimbursements to the same amount. First off, usual and customary is not tied to a percentage of Medicare rates. And determining what UCR means, it's more of an art, not a science. I mean, have you tried asking the payers how they came up with UCR? They just give you the runaround because they really aren't even able to define it. Second, payers are not always forthcoming with pricing, or they could just be incorrect. So for instance, the insurance company might tell you that the reimbursements are 150% of Medicare rates, but the policy actually states usual and customary is based off of what other providers in the area are charging. Finally, you should try to keep track of the different insurance policies that you encounter in your area. Again, there is no way that every single payer is reimbursing at the same amount for usual and customary. All payers have different policies that they sell to employer groups with different benefit levels, as we discussed before. How do you collect more than usual and customary? Usual and customary, it is a vague term, but that's why you're able to negotiate it. And in order to do so, you'll need the data, insurance policies, and of course, experience and expertise to be successful. All right, now we will dive into some questions that we've been asked on different out-of-network insurance policies. So the first question is, what is a limited benefit policy? And this is a policy that puts restrictions on the calculation of reimbursement. So as opposed to UCR being vague, this can be defined. So frequently it's, these policies tie benefits to a percentage of Medicare. It could be 100% of Medicare, 150% of Medicare, somewhere in between. What are examples of limited benefit policies? United Healthcare has MNRP policies, and Cigna calls theirs MRCs. Both of them limit their reimbursements to a percentage of Medicare rates, and by accepting these patients, you're essentially accepting Medicare rates. Now, the good news here is that you're typically able to negotiate higher and sometimes even much higher than those defined Medicare rates. How do I know if the patient has a limited benefit policy? You should specifically ask the insurance company when you're verifying benefits. During that call, you can ask these questions. Can cases involving international patients be negotiated? So yes, but there are some nuances that make it different from US-based policies. International insurance companies are much more aggressive, and they know it's often difficult for you to find the patient, let alone collect from them. So citizens of another country, they often have a special travel policy with very limited benefits. And in addition, there are no insurance regulations that the foreign carrier has to be bound by. So, whereas a domestic U.S. insurance company is required to have proper and timely payment to the provider, or else they're going to be fined or otherwise penalized by the state insurance commission, a foreign company has no such restrictions. Therefore, there's no incentive to the foreign carrier to pay more rather than less. But again, with proper data processes and most importantly, persistence, you can be successful with these patients. All right, the next section now is going to regard negotiating settlement offers. And the first question in this section is, what is the incentive to agree to any of these proposals when the provider is out of network with the payer? Well, frankly, you make more money because you're typically able to negotiate higher reimbursements than just waiting on the insurance company to pay you. Also, you receive the payments faster, and there is a higher success rate in negotiating upfront prior to payment as opposed to appealing on the back end after payment's already been made. Why would I negotiate offers from companies like MultiPlan? I expect 100% of my charges, and we all do, but in a perfect world, out-of-network should be reimbursed at 100% of billed charges. But over the years, payers have implemented numerous bill minimization tactics, so they only reimburse you at a fraction of what you charge. So you should definitely negotiate these proposals because in reality, if you don't, the payers are most likely repricing your bill to much lower levels than what you were offered. Any tips for negotiating the single case agreement? Surprise, I'm going to say persistence. I've been saying it throughout the entire presentation. Just don't give in easily if you think that their offer is inadequate. But also another good tip is to obtain the data to prove that insurance companies' payments are inadequate, aggregated in some way. You need to be able to argue that the insurance company's reimbursement level is inconsistent with your own history, and preferably the history of other providers in your community if possible. Remember, these insurance companies and their vendors, they're tracking everything that you do. I mean, down to the names, titles, discount levels that everybody in your business office gives them. And then you can also try to track the different insurance policies that you encounter, because this will give you an idea of how the policy should reimburse. What do you think about our strategy of never accepting more than 10% discounts? Candidly, if you have a policy of never going below 90% or any set amount, the chances are that some insurance companies are repricing your bills at a much lower rate. You know, the reality is that some payers and some policies, they just won't agree to a 10% discount. And what happens is those payers, you know, they won't contact you to negotiate, and they just end up repricing it down to whatever they decide to be usual and customary, which again is typically lower than half of your bill charges. So we've been able to go to these insurance companies and prevent them in the future from repricing these bills down to usual and customary. So instead, you should be, negotiating settlements at the highest amounts per that policy. Won't negotiating aggressively ruin my relationship with these vendors? And we hear providers say this all the time, that they have a great relationship with their vendors. And that's exactly what these vendors want you to believe. But you got to remember that these vendors are not your friends. They are compensated on how much money they save their clients, who are the insurance companies. So they're continuously trying to find new ways to pay you, the provider, less money. Now, you can also think about your quote-unquote relationships in this way. So the vendors, their ultimate goal is to negotiate settlements against every single provider. And in the grand scheme of things, no offense, but you're one grain of sand in a mile-long beach from the payer's perspective. On a one-on-one basis, they're trying to make you think that you're friends with them, so you think you're getting a good deal, but that's just not the case. In reality, the vendors, they report back to the insurance companies by batching results by TIN and not by your specific name. So in the end, it's just you're a number to these payers. Is it appropriate that vendors often give me less than a day to negotiate? When the vendors opt to settle a case through negotiations, they often do so by sending proposals that have short turnaround times, and their goal basically is just to put pressure on the provider to settle quickly. And sometimes those turnaround times are real, but sometimes they aren't. Once we agree to a discount, can the payer change their mind? Unfortunately, yes, they can. For one, it could be as simple as the payer accidentally sending the claim to be negotiated when it should have just been repriced. But there could also be something in the policy they draw onto that changes the settlement. So it could be something like a multiple procedure reduction or non-covered. Unfortunately, these signed settlement offers, they're not binding, but if you see any discrepancies, always go back and fight them and try to get it overturned. If we decline a single case agreement, can we bill the patient? Yes, you can. Since you did not reach a deal with the payer, you can do whatever you want. If we accept a single case agreement, can we bill the patient for the discounted amount? In this case, you cannot bill the patient for the discounted amount because you have come to an agreement with the vendor. But I also want to mention that you cannot appeal the case if you have signed the agreement. One thing you can do, though, is you can bill the patient for any patient responsibility like deductibles and copays. Is it better to decline an agreement if we don't agree with the reimbursement amount? This is a yes and no. So it depends on policy type and how it would reimburse otherwise. So for instance, you may have to accept a lower amount for a limited benefit policy than you would for a policy that's based on usual and customary. Is it good to sign up with third-party portals? All right, so first I want to give some background information on what this is, because some vendors, they use a portal to send these proposed single case agreements to providers instead of faxing or emailing them to you. And providers use it because it's sold to them as being easier, more efficient, and so on. But going back to this question, no, it's generally not good to sign up with these third-party portals. What providers don't realize is that the portals are set up so you can't negotiate the case. And in fact, some vendors won't even take calls regarding cases that were transmitted using the portal. Also, you won't know things like non-covered amounts or special policy types. Okay, now let's do a shorter section on appealing underpayments. And the first question is, as an out-of-network provider, can we appeal low reimbursements for claims? Yes, of course. Every provider should put together a comprehensive appeal process to combat the insurance companies when they've been severely underpaid. What's the best way to successfully appeal underpaid bills? Well, to start, you need resources devoted to appealing cases because it won't just happen by itself. These resources, they need data to make arguments to the payer. And you also need a plan or a method to your appeal process, meaning you need to know when to write letters or when and how to escalate the case. You also need to be persistent. The payer and the vendors, they put up obstacles to success. They're banking that you get up and walk away because they know that you're focused on treating patients and just don't always have the time to continue the fight. What are best practices to appeal an underpayment? So you definitely need a rigorous appeal process. It's not just, send a letter and hope for the best. It can be very labor intensive to appeal an underpayment and obtain a higher payment. So I'm going to provide some of the steps of a successful appeal process here. The first step is the initial intake, so you just want to ensure that you have the documentation necessary to handle the claim, and this includes the UB or CMS 1500, whatever it is you bill out on, the explanation of benefits, the assignment of benefits, and any billing and collections notes. Next step is payer verification, so you'll contact the payer to verify the patient and bill information, and also you want to make sure that you obtain a verbal explanation for why they reduced your charges. Then we devise our strategy. So this will involve formulating the facts and arguments to be made to the payer. Of course, here at CollectRx, we use our Crixus Business Intelligence engine to assist us. So you're going to want to come up with your own strategy and develop a way to aggregate data as well. Step 4 is payer engagement. You're going to engage the payer and present the relevant facts and arguments to the payer, but to be successful with appeals, you have to be able to call every day, write letters every day, escalate when necessary to the state insurance commission, for example. And once you fully present the information to the payer, it'll take them several weeks to reach a decision. And in that time, you need to make sure that you're following up with them. And that leads us to settlement agreements and post-settlement follow-up. Not surprisingly, these payers, they don't always want to pay on time or in the correct amount. So make sure that you are successful in getting an additional payment by following up with the insurance companies and ensuring that money is in your bank. What is an assignment of benefits? The assignment of benefits is a very important document to ensure that you're paid. It's simply an arrangement by which a patient requests that their insurance payments be made directly to your center or practice. Any tips on the assignment of benefits? So with respect to the assignment of benefits, you want to ensure yours is well drafted. We're not offering legal advice, but here are a few of the items you may want to ensure that are included. So first off, you want to make sure that it assigns the right to appeal and the right to receive relevant documentation. It should refer to the provider as the patient's authorized representative, and it should properly reference ERISA and a full, fair review of claims. Because if your assignment of benefits is inadequate, it's yet another roadblock that the payers use to stop you from getting reimbursed on your out-of-network bills. Okay, what about insurance companies paying initially but then recouping the money later? You should definitely fight these. It happens, and you need to fight them. At CollectRx, we handle that as part of our appeal service, so you want to make sure that you have the proper documentation, you present the relevant data and arguments to why the payer should not recoup the money, and be persistent in following up with the payer. Okay, this is the final section, and it's on third-party rental agreements, also sometimes called silent PPOs. So first, the question is, what is a silent PPO or a third-party rental agreement? So these are agreements that are signed not with an individual payer, but with a third party that contracts with a lot of payers. So think of these third parties like middlemen of sorts. It brings together payers and providers to participate in contracts that often are not favorable from a provider perspective for a number of reasons. They're also often offered to other payers and networks that the provider doesn't even know about. So that's why you sometimes hear them referred to as silent PPOs. And, you know, they sound easy. It's one contract, and somehow you all of a sudden have a contract with all of the payers that are signed up on their network on the other end. Most providers, however, as we'll talk about in a bit, don't understand how detrimental they can be. We can provide a complimentary analysis if you're in one of these agreements or if you're considering entering into one of these agreements. How do I know when a third-party rental agreement is going to be applied? Unfortunately, you don't know. It is completely up to the insurance company to determine when they will utilize it, and their decision is based on whatever pricing will yield the lowest payment to you. And so this could either be the third-party rental agreement rate, or it could be what the patient's policy defines out-of-network benefits to be. So even if a patient has a third party's logo on their insurance card when they come in, it does not necessarily mean that it will be utilized. Why do so many providers contract with third-party rental agreements or silent PPOs? Well, they do it because it's easier. The third parties are selling the stream of reduced paperwork, decreased negotiating time, and quote-unquote consistent reimbursements with this one contract. But the reality is that there are many pitfalls they apply that result in these contracts being another form of cost containment. I mean, just think, how can it be so easy to negotiate one contract with a third party that any insurance company can utilize, but if you try to negotiate a contract directly with the payer, it can take months and it's typically at a much lower rate. Why don't the payers always use my third-party contract? Well, first off, there's no requirement that the payer has to use any particular contract. These contracts act as caps to your out-of-network reimbursement, so they'll never reimburse you higher than what your contracted rate is. So let's say you negotiated a third-party contract at 70% of charges. Now you have a policy that comes in and it reimburses at 40% of charges. Well, there's no way that the insurance company is going to choose to use your 70% contract because they're going to end up paying you more. But if the policy for that patient reimburses at 80%, then of course the payer is going to use the contract because now they only have to reimburse you at 70% instead of the higher 80%. Why does the explanation of benefits sometimes state that the third-party contract was used, but the bill was not reimbursed according to the contract? So the vendors, they write language in the contract that allows for reductions like the usual and customary cuts, multiple procedure reductions, and code edits that unexpectedly drive reimbursements downwards. Now, another issue is that sometimes providers don't realize that the reimbursement levels are based on a percentage of the allowed charges, not your billed charges. So this means that payers first take a cut to arrive at the allowed amount, and then they apply the discount to the lowered amount. So I'm going to throw out some numbers here, but try to follow along. So let's say you have a $10,000 bill, and your contract is, again, for 70%, but it's for allowed charges instead of billed charges. So that means that the insurance company, they're going to decide what they allow. So they decide, hey, $6,000 is going to be the allowed amount. Then they apply your 70% contract, and that yields a payment of $4,200. Now, many providers, not realizing that the contract is based off of allowed amounts, are actually expecting $7,000 instead of that $4,200. How do I track if my third-party rental agreements are being applied correctly? You need to check your EOBs. Many providers, they just unfortunately don't even track payments to see whether they're being paid correctly. And it's hard to blame them. These EOBs, they're being written in ways that makes it very difficult to read. But once again, it is important that you check your EOBs to make sure you're being paid correctly. Why do I receive settlement offers when I have a contract? Okay, so this is, again, another tactic the insurance companies deploy in trying to beat a contracted rate. It's by negotiating a lower rate. So, for example, they might have, let's say you have a third-party rental agreement that calls for a contract at 65% or reimbursement at 65%. The insurance company, they will give the case to another vendor, and they're going to see if that vendor can beat your 65% contracted rate. So even if that other vendor negotiates 60% of charges, that's still a huge win for the insurance company. Okay, now a word about outsourcing. I know this will sound self-serving, and frankly it is, but providers, you should consider outsourcing to companies that are well-seasoned in the reimbursement arena. You may not always have the time, data, or expertise to be successful with out-of-network reimbursements. And think about the fact that these payers, with their vast data and resources, I mean, they don't handle it themselves. They outsource it to these third-party vendors. So at least considering it should be on your mind. But in summary, I hope that we've answered some of your most frequently asked questions and have familiarized you with some of the intricacies that are required to successfully run an out-of-network operation. So I want to thank you for your time. I hope you found the session useful, and I can take some questions now.
Thank you, Richa, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So our first question over here is, why do you say third-party rental agreements are detrimental?
Well, so the insurance companies, they write a lot of language that allows for pitfalls. I think I alluded to this, but didn't really go into full detail. I did mention though that there's sometimes they include reductions like usual and customary cuts in the contract language. Also, they don't bring you more patients, because if you think about it, with a contract with a direct payer, they do make up the volume discount with referring you more patients, but with these third-party contracts, it doesn't happen there. Also, there's something that we call double dipping. This means that they're taking a discount from you with this contract, but they're also taking higher out-of-network benefits as opposed to the in-network benefits that you get with regular managed care contracts. I mean, even if you just take a look at the MultiPlan's website, it states on the homepage that MultiPlan, they help their payers manage the cost to care and not the providers.
Got it. Well, thank you for that informative response. What can I do if they keep telling me to call back because my appeal's being reprocessed?
So I know you're going to be annoyed by this, but it's persistence, of course. I know I've said it over and over again. And it's very annoying when you hear this from insurance companies also, because they are playing a game and they're anticipating that you stop. The payers, they're just making it hard to negotiate, and this is just one simple way that they're doing it. But another thing outside of persistence is that you can always escalate the appeal. You can take it to higher levels within the insurance company, or you can also take it to outside entities. Like I've talked about the State Insurance Commission a couple of times, so that can work as well.
Okay, great. The next question is, you said the phone was the best way to negotiate. What about the portal?
Oh, okay. I think that goes back to the FAQ when I was talking about third-party portals. And, sometimes, so it does seem easier because there's no paperwork and it's faster because of the technology. But remember, you're typically unable to counteroffer with these. You can only accept or decline the offers, so you're given no leeway. It's just not helpful to providers.
Okay, got it. Our next question is, what factors should I consider if I want to look at going out of network?
Good question. So this one is, obviously you want to take a look at what your employer mix looks like, because as we discussed earlier, employer preference, that's one of the biggest factors to how a payer reimburses. But you can also look at things like what the payer mix is in your geographical area. Also what, for your most common procedures, what in-network rates are like versus out-of-network rates.
Okay, great. And I think we have time for one last question over here, which is what should payers do to defend itself against payer challenges?
Stay persistent. It's the number one key, because the bottom line is you need to devote the resources and time to be successful. But you can also do things like don't sign third-party rental agreements. You've got to devise a robust appeal process. You need to read your EOBs. We've given other presentations, and that's probably, again, one of the biggest takeaways is providers have to read their EOBs. They make it difficult, but it tells a lot of what they're doing and how they're reimbursing. Out of network, it's still viable. It's just gotten harder to negotiate.
Okay, got it. Well, that is all the time we have for today. I want to thank Rita and CollectRx for this excellent presentation, and to our audience for participating. Enjoy the rest of your day, and we look forward to having you join us for future webinars.